So for those of you who were here, thank you. Um, I'm luckily I have a computer today because I about threw this one through a wall yesterday. I was on the phone with Justin trying to get it all figured out. And it turns out when we finally did get the link posted, it wasn't posted in the right place. Anyway, it's a nightmare. It's our fault. Think we've got it figured out on the college side. I spent about 2 hours this morning going back and forth with IT, and basically they've had to give me another account because apparently the account that I was assigned isn't working. So we're going to try that. Right now, we're still using my personal one, which doesn't bother me either way. But those of you who are not here will have the opportunity to listen to the recording. At some point in time during the recording, I'm going to give a code word. That code word will be the answer to the quiz. Even if you are here in class today, you will still take the quiz. Okay. So very, very important. Everyone has to take the quiz because it'll count for your your attendance. I may start doing that every class anyway. That way I've got an actual record of attendance, other than me having to manually keep up with this roster that they gave me. And then you actually get points for showing up to lecture. So we're going to go through tonight. We're going to talk about medication safety, and answer any questions that you all have. So I guess first and foremost, we'll start with that. Does anybody have any questions before we get started?
Yeah. How long does it typically take for us to get our CPR card in the email?
Normally it's 24 hours, but we haven't submitted it yet because normally your CPR course is run through your instructor, but I am not a CPR instructor for AB Tech. I'm a CPR instructor for CPCC. And so I emailed Madeline with the roster, and they're going to run it through their side. So as soon as I'm told, yeah, it's in, then I'll send out a message on announcements and tell you guys, hey, start looking out for it. Because it doesn't take, but usually, sometimes it'll take less than 24 hours, and it'll come to your email. So I'll let you know as soon as I have a date on that. It shouldn't be much longer.
All right, cool.
Any other questions?
I've got just want to make sure he's okay. I've got a meeting at 6 o'clock, so I'll be in for like this first part, and then I've got to hop off.
You're fine. We may actually be done by then because it's actually a rather short night because we're just going to talk about medication errors. So that's a rather short chapter. We've gone through a lot of the airway stuff already, and there is a video on the shock lecture already on there, or will be on there. So I'll upload that tonight, and so you'll have that extra lecture on that as well. So we'll just be going through the medication stuff tonight. Anything else?
Hey, Drew, this is Daniel. Is there a way for us to communicate as a group or as a team? Last night it just kind of felt out of communication on everything.
Yeah, and normally what I'll do is I have everybody's email address, but I couldn't log into anything. I couldn't get into the AB Tech email. I couldn't get into Zoom. I couldn't get into anything. I was finally able to get into the Compass. What I could do is typically for my CPCC classes, I have a Discord server that I have set up. I could set up a Discord server for this class. That way I could communicate directly with whoever signed up for the server.
Okay. I didn't know if there was something in Compass that you could unlock or something that would allow us to.
There's a messaging system, but if I can't get into Compass, it does me no good, which
Right.
was the issue yesterday, and which is what AB Tech, the IT department, has been dealing with not dealing with all morning, but I was dealing with them.
Yeah,
So-
but that's only one-way communication. You can post on there, but we can't respond or anything or ask questions.
Well, no, there's a messaging system on there that you can use. But if I can't log into it, then it does you no good.
Okay.
And so what I'm talking about is taking it off that platform completely, by creating a Discord server.
Okay. Thanks.
No problem. I'll work on that.
So is it possible to create a thread in like our announcements that we can respond to? Open up the response system. That's
So
what we
again,
need to do.
right, again, if I can't get into Compass, then it doesn't do any good.
So
that-
won't let us communicate when you're offline?
No. You can message me, but it doesn't, the only time I would see it is if
I think what
We're-
what
we're
they're
asking
saying
for
is
us
to communicate
Not with you, with us.
amongst each other.
I don't know if you
creating
guys
group
can
chat.
communicate. I don't know if you guys can communicate with each other unless through the messaging system. I'd have to investigate that. But again, the Discord server, you all can communicate with each other on. So if we do something like that, my preference would be to take it off of an AB Tech site that way, because let's say what happened yesterday where, we can't get in, I can't get in. Let's say it happens to everybody. We take it on a different program that has nothing to do with AV Tech. And so if there is a technical issue, say with Compass or Zoom or whatever, then you guys can communicate with each other without having to go through all that. Does that make sense?
Yeah, Discord's a good way to go.
Yeah, we've used it. I've used it every semester at CP for the past, I think, 2 years. It's great because if the internal communication system goes down at CP, which it's done before, then I have that ability to just go on there and be like, hey, and students can communicate with each other directly on Discord. They can communicate as a group. They can set up their own chat rooms, that whole thing. And so it to me, that seems to work better than trying to do something through.
And it's just an app you download on your phone.
Yeah, it's free. It doesn't cost anything. Because I'm sure like I don't know about the announcements. I can create a discussion board that you all can talk to each other on. But the problem with that is it has to be affiliated with an assignment. And so that kind of skews the grading. So I can't, and then I have to go in and individually mark each one of those as a 0, or not a 0, but a non-graded item. So I'll get the Discord server set up, and then that way, because that doesn't take any time to do. And then I can post the link to that in the announcements. You guys click on that, download Discord, and that'll be that. And it, like I said, it saved us last spring semester. There was what was it? It was like a water leak or something like that. And they shut down Central Campus like 30 minutes before class was supposed to start. And I was in my car. So I can't obviously pull up my email or pull up Brightspace, which is basically our Compass, while I'm driving down the road. So I was just able to whip out Discord, type a quick message out to students, hey, class is canceled for the morning. I'll keep everybody updated. And then they were all able to get to it. So. Yep. That's it. And I think the link that I post on the announcements, I'm pretty sure that will prompt you to download it if you hit it from your phone. So, all right, any other questions? I think it's a very good idea. I think it's a good idea. I normally do that with my CP classes, so it makes sense that we would do it with this class too.
Are the grades updated the way they should be? I'm just messing with you. Just try and lighten the mood.
Everyone except yours. Actually, I need to deduct 10 points off your overall letter grade. I should probably do that. All right. Anything else before we get going on this? All right. So we're going to talk tonight about medications and medication errors and how important that it is that we pay attention to what we're doing and that we follow the patient rights and all that fun stuff. Before we do all that, we're going to actually play a video. Two videos actually. Okay. Tony, give me a thumbs up if you can hear the sound from this.
My daughter, Emily Christine Jerry, was born February 24th of 2004. She was playing in the backyard with her brother and sister, Nate and Catherine. And I noticed that every so often, Emily would stop and grab her side and wince. After witnessing this occur 3 or 4 times during the course of the afternoon, neither one of us as parents really thought much of it, but we knew that we needed to take her in to have her checked out. We took Emily to a leading pediatric facility in Cleveland, Ohio, and they had decided to run Emily through the MRI scanner. And there was a grapefruit-sized mass in Emily's abdomen. They prepared us to expect the worst. They set our expectations, expect that your little girl is going to lose a significant amount of weight during the course of treatment. She's going to lose her beautiful blonde ringlets. She'd be vomiting, most likely, and things of that nature. She didn't start losing those beautiful blonde ringlets of hair until January of 2006. But I knew in the back of my mind that quite possibly the tumor wasn't responding to that course of treatment. So the decision was made to run Emily through the MRI scanner again. Emily's tumor had completely disappeared. There wasn't even any residual scar tissue remaining in her abdomen that they had anticipated. A miracle had occurred. And those are the caregiver's words, not mine. At this point, they recommended one final 3-day round of chemotherapy, just to make sure that there wasn't any residual cancer cells remaining. I arrived about 10 or 15 minutes after they had started Emily's IV that day. And when I walked into Emily's treatment room, Emily was unconscious. I was thinking to myself, how could this have happened? I mean, she was just fine. What was found to have happened was the clinical pharmacy that day ran out of standard bags of saline with 0.9% sodium chloride. And so this young pharmacy technician decided to take an empty compounding bag, and she saw 3 vials of what's called hypertonic saline, which is 23.4% in concentration. She filled this empty compounding bag with those 3 vials of hypertonic saline and used that as the base solution for Emily's chemotherapy that day. She thought she was doing the right thing. That Wednesday was when my wife and I had to make the most difficult decision of our lives, which was, after multiple EEGs showed little to no brain activity, the decision was made to take Emily off of life support. That day is still a blur to me emotionally. I was packing some of Emily's things from her treatment room into the back of our SUV, which happened to be parked on the top floor of the parking garage at the the facility that day. And I saw the car seat in the back of that SUV, and I was thinking, you know, maybe I should just take a flying leap off this parking garage and go and join my little girl. I'd never had those kind of thoughts or feelings before in my life. And it was almost at that moment that I decided to embark on this career. I don't want to say that it was chosen, that I chose it. I believe it was chosen for me. And work so passionately on through my advocacy efforts to try to find or be an active part of the solution to preventable medical errors. And so in striving to be part of the solution, I've been working very hard through the programming of the Emily Jerry Foundation. I believe that we can get to 0 deaths in the United States from preventable medical errors, because they're just that, preventable.
Hey, Andrew, you may be on mute if you're talking.
I'm not. I'm prepping the next video. Thank you, though.
What does the word wince mean? Stand for?
I'm sorry, what?
What does that? He said she would grab her side and wince.
Wince, as like she would squint her eyes and make a face like she was in pain.
Oh, squint. Okay.
You know, like a person winces in pain.
I don't believe in hope anymore, and I never use the word hope anymore, ever. Like, I won't even just, oh, I hope you feel better. Like, I hope it goes well. Like, what's the point of that? What is the point of that? I just sort of accept things as they come, and I don't pray anymore, because I prayed every day. And I had so many friends and family, across the world praying for Nora, and it made no difference. 2 months after she came home from the NICU, she turned blue. Doctor comes in and says, the things are going to be very different from now on because Nora has pulmonary hypertension. They were optimistic that Nora might not follow the normal course of the disease, that she might, instead of it progressing and getting worse, they told us that she would get better because her pulmonary hypertension was caused by being a preemie. And for 2.5 years, the disease didn't progress. And she did grow. She grew, she ate well, she developed, she was super smart.
Very strong. She was running around like crazy. I mean, she was still in oxygen, but she was moving all over the house. She was in the backyard, playing with a baseball bat and stuff. So that was really fun.
First couple times she fainted, I didn't know how serious it was. I didn't know. And the doctors were kind of taking a wait and see attitude, I think. And then as she continued to faint, then they started to explain how serious it was. In October of 2012, she had a central line placed, and that central line delivered a continuous infusion of this pulmonary hypertension medication. So basically what happened is she developed an allergy to something with the dressing change. We don't know what. And so the home health nurse told us to change the dressing change protocol. And sure enough, not too long after we switched protocols, she got a central line infection. Like, I'm talking about how, she could run like any other kid. Well, even after that first infection, she couldn't. They switched her back to the central line, but they followed the same, lesser dressing change protocol. Clearly didn't work. She just kept getting worse and worse and worse. hear her little voice in the mask, and she said, please help me feel better. And I cradled her in my lap. Like I would when she was a baby, but she was such a big girl now, you know. She was really tall and her long legs, and I just held her. And she just slipped away.
The thing is that it's such an important job to work in healthcare and provide care. Compared to any other business, you almost have to expect a sort of higher standard than almost in any other field.
How do you make sure that the staff is implementing what we know works? And I think that there has to be a culture at every hospital that says we're not going to accept central line infections. We're not going to accept them.
All right. Any dry eyes? These are hard videos to watch. These are very difficult to watch. They're very difficult to watch because they both have one thing in common. Well, they have several things in common. They have a very, very important thing in common. Who can tell me what it is?
They're preventable.
Preventable. It's 100% preventable every single time. There's hundreds of these videos on YouTube. I can go do a search for patient death due to medication or improper procedure error, and it's going to give you hundreds of these stories, these same exact stories. And across every single one of them, and I've watched them. I've sat up late at night and I've watched these because I try to find ones that I think are relevant to the class. I try to find ones that I think are going to make the most sense that aren't going to be 20 minutes long. And so I've gone through a lot of these, and every single one of them, they all come down to the same thing: is it was a mistake that could have been prevented. The scary thing is it can be anyone. It's very rarely it's stuff like this, malicious in intent. A lot of times it's not even because the person who did it shouldn't have been doing what they were doing, or they're poorly educated. A lot of times it comes down to they were in a hurry. They were overworked. They hadn't slept enough. Or they just made a simple mistake. These are things that every single person who's on this call, it could happen to you. And we've all made mistakes as healthcare providers. I tell the story of a patient whom we went out to their house because he was having trouble breathing. And he'd been having trouble breathing for 4 days. And we got there and you could hear the fluid in his lungs from the next room over. I could hear him breathing when I walked in the door, and I was like, this guy is bad. And my partner knew it too. We walked back there, and the patient was not doing well, and he was too far gone for CPAP. And I looked at my partner, I said, we're gonna have to intubate this patient. There's no way around it. And we got the patient out of the truck, and I prepared for what we call rapid sequence induction. And it's a very specific process, has lots of steps to it. You have to follow a checklist, and I'd follow the checklist to the letter, and had all my drugs drawn up and everything. And I double checked the drugs, and I gave the patient medication. And I gave him a sedative first, which is what we're supposed to do. And the moment I gave him the sedative, the patient went to cardiac arrest. And I remember watching it because I was dumbfounded because that had never happened to me before. And we worked the patient, and we got him to the hospital and worked him some more, and we never got him back. And I remember talking to the doctor, And I said, I can't help but feeling like I killed this guy. Like I know that I followed the policy and the protocol and I can't find a mistake that I made, but I feel like I killed this guy. And the doctor looked at me in the face like, it's because you did. And that didn't make me feel any better. I was kind of hoping he was going to go, no, you did everything right. And he said, no, he said, you did. He said, you killed that guy. He said, did you followed your policy and procedure? And he said, to be honest with you, if this patient would have presented this way to the hospital, we would have done the same thing you did. But it doesn't stop the fact the patient had a negative reaction to medication. So there's times when these reactions can't be helped. Like you follow the policy and procedure, you do the right thing, and you're still going to have a negative outcome. But that's a lot easier to explain to a family than the situations that we saw with Nora and in the first video, because there's no excuses for that. And a lot of healthcare providers lose their jobs every year because they make these mistakes. Does anybody know statistically how likely it is that a patient will deal with a medication error in the healthcare setting? There's a few stats out here on it, so there might be some varying answers, but who wants to give me a guess? Like how often? What was that, Aurora?
Maybe 40.
What, you saying 1 in 40?
40%.
Oh, 40%. Okay. So she's saying 40%. Anybody else?
25.
25%. Okay. Anybody else? So I got the most recent stats. 7 million American patients per year are impacted by a medication error. Okay. About 10,000 of them will die. About 500,000 of them will suffer a long-term debilitating injury. I firmly believe, like the gentleman said in the first video, that we can get those numbers to zero because it all comes down to us as providers. So we look at these videos before we start today because I kind of want you guys to have that mindset as we go into talking about what we're going to talk about, because this isn't just information. Everything we do has the ability to impact a patient's life. Everything. But I mean, this is one of those things that if done incorrectly, we can kill people. And just because, y'all are going to school to be EMTs does not mean that the medications that y'all give won't cause that. Nitroglycerin, which we already our dose of nitroglycerin, critical care wise, is well over the amount we should be giving to begin with. And so if given incorrectly, that can kill people. Aspirin can kill people if given incorrectly. Epi can kill people. Albuterol can kill people if given incorrectly. And so we just need to keep these things in mind as we go through these lectures today, or this lecture today, because I want everybody to understand that this is, there's some cool things that we get to do as providers. But at the end of the day, everything we do has the ability to affect somebody's life. Though again, you have these lectures online, so we're not going to dig through all this. I just want to talk about a few things, and then I'm going to give you your time back this evening. We talked about this last weekend, the importance of perfusion. And next class, when we get together, we're going to talk about how to maintain airways. But after the airway, one of the most common and important interventions that you're going to see on the healthcare or in the EMT world is medication intervention. It changes every year, but we have about 100 different medications that EMS can give. And as an EMT, I think you're approved for somewhere around 18 to 20 of those. we give them for varying reasons. We give them for pain, those are analgesics, and then of course we can give them to improve a condition. What would be a medication that we would give for pain control?
Ibuprofen.
Ibuprofen. Yeah, when you turn 40, you just keep one by your bed all the time. I got one sitting right next to my bed, 2 in the morning, 2 at night. What is a medication that we would give to improve a patient's condition?
Oxygen.
Yeah. Oxygen, albuterol, nitro, epi, those sort of things. One thing we want to be conscious of when it comes to pain control, and we don't go into this in the lecture, which is why I want to talk about it here, is equity in pain control. So I'm one of those people that when you tell me something, when you say this certain thing exists or whatever, I need to see the data behind it. You can't just tell me that a certain thing is a fact and there be no data behind that. So if I'm talking about something in an educated manner, then I have taken the time to look up the data. I don't like to just espouse things that I've heard from others. There is plenty of data out there that shows that there is serious inequity in how we dole out analgesics in healthcare. Now, it's not just EMS. I mean, EMS actually does better than some. The ER is one of the worst offenders. What do you guys think I mean by that? What do you think I mean by, I'm sorry, Aurora, I didn't mean to make you yawn. What do you guys think I mean by there's inequity in pain control in healthcare? What does that mean?
Could you repeat that?
Sure. When I say there's inequity in pain control, meaning we are not distributing pain medicine in an equitable manner to our patients. What am I saying?
You're saying there's bias?
Where?
Say, somebody looks like a homeless person comes in and asks for pain medicine. They could legitimately be in pain, but they're choosing not to treat because they think the person may be a druggie or something.
Yep. What else? Well, give me another example of bias in pain control.
One personal experience I have is with gout. I've had severe gout where it feels like a broken bone, broken foot. I mean, worst pain I've ever had. If I had, I thought about taking a shotgun and just blowing my foot off to alleviate the pain. There's a lot of people in the medical community that's never experienced that. And, they just see gout as an inflammation and it's not understood in pain. Working at the VA, I hear cases like that all the time. And, insurance insurance doesn't want to cover it as an emergency, but the person experiencing severe pain causing mental issues. So there's some bias there, or lack of knowledge, or lack of experience of that kind of pain.
Okay. Aurora, you turned your mic on for a second. Were you going to say something too?
Yeah, I was just thinking about pain tolerance and chronic pain. You can't really, pain is something very hard to treat. So most times people are just stuck with it and there's nothing really much that you can do.
Yeah. As someone who lives with a person who has chronic pain and watching what she has to go through, this is somebody who does not take pain medicine unless she absolutely has to. But when she has to have it, she has to have it. And it's like pulling teeth getting it. Anybody else? There's another thing we want to make sure we're covering when we're talking about inequity here.
Well, pain is also subjective to, it's what that person's feeling. It's not something that can be measured and, have a factual evidence of.
It's hard to qualify pain. You can't
Yeah.
look at someone's vital signs because particularly chronic pain patients, going back what Aurora was talking about, chronic pain patients, their vital signs don't go up and down like someone with acute pain would be experiencing. What about racial bias? What about bias based on sex? The data is really clear, guys. Really clear that if you're a Black female in the United States and you go into the hospital, you are 38% less likely, 38% less likely to get pain control than anyone else. There's another case study that looked at Hispanic males who went in with long bone fractures were significantly less likely to get analgesics for pain control than white males who were in the study. I'm not trying to turn this into a lecture based around race, or maybe I kind of am, but I said very early on that I believe EMS is one of those professions that it's kind of hard to look at things through an extremely biased lens, because you see everyone from different walks of life and you realize that everybody's made up of the same material, bleeds the same color and all that stuff. But it's really easy sometimes to get blindsided by your bias when it comes to certain things like chronic pain, frequent flyers, homelessness, patients who don't speak English. And as we said earlier, not fully understanding that pain is a subjective symptom that we can't qualify. There's no way we can qualify whether a patient's experiencing pain. People say, well, Drew, there are people who call 911 and fake being in pain for pain medicine all the time. You're right. It does happen, but it doesn't happen as often as you think it does. And the numbers don't lie about that either. But even the ones that are lying to get pain medicine, I want you to think about what's worse. What's worse? Giving a junkie 100 micrograms of fentanyl, or withholding pain medicine from somebody who is in pain. I will give the pain medicine, I will give the person who is seeking drugs medicine all day long if it means that I'm not withholding it, if I'm not potentially withholding it from somebody who needs it. Because just because you're addicted to something doesn't mean you can't experience pain. And just because you have a history of mental instability doesn't mean that you're not experiencing pain. Just because you don't speak English doesn't mean you're not experiencing pain. And just because you are a different color than me doesn't mean you're not experiencing pain. We have to make sure that as healthcare providers, we are being equitable, and not just in how we provide our life-saving interventions, but our palliative care as well. And that means that taking patients who, might otherwise get written off by the system and providing them the care that they need early on, that sets a precedent that's really hard for other healthcare providers to break. We've got to get past this point of, oh, well, this is Miss So-and-so and she's a frequent flyer. She's always calling for Miss So-and-so. She might have, pancreatitis, chronic pancreatitis. She might have fibromyalgia. There's all kinds of different chronic diseases that can result in pain. And so my point from this, when we talk about alleviating pain, is be conscious of any bias that you may have, and give people the benefit of the doubt. and also be conscious of what the statistics say. I don't know. There's a lot of studies that have been done, and because I had a student one time that said, well, that's just a sign of, we're going back to the, Black females and Hispanic males studies. Well, that's just a sign of overt racism in healthcare. I don't think that's what that study proves. And I think that there's other studies that support what I'm getting ready to say. We have a hard time treating people that don't look like us, because we know what we look like when we are in pain. We know how we respond to certain situations. And if we can't identify a part of ourselves in our patient, then it's a lot harder for us to be empathetic. And that is supported by a lot of psychological studies that have been done when they look at like the Wong-Baker Faces pain scale. When they took those pain scale, that like the hand-drawn faces, and they basically superimposed a person's face on it. And if that person was the same color as the person who was taking the test, they were more accurately predicting what that person's pain level was. But when they changed the race of the person on the card of the face, it made it a lot more difficult for them to predict what the pain level was. And so this is not a me beating everybody up saying, well, everybody works in healthcare is racist, because that's not the case. I think we just have to be conscious of the fact that not every patient is going to respond to things the way that we are going to respond to them. And because of that, all we can do is rely on our patient presentation and what they're telling us about their condition. If a patient tells me I'm complaining of 8 out of 10 pain, and I'm that they appear anxious, and they're having a hard time sitting still, and they have a history of chronic pain issues, I'm gonna treat that as as it should be treated, instead of withholding care that a patient needs. Talking about gout, I've never had gout, but I've had kidney stones before, 2 of them. And the first time I had it, when I went to my doctor told me, that's why he's not my doctor anymore. He said, just go home and take ibuprofen and have a few beers. Well, I don't drink, so that's one. And then ibuprofen, I was eating ibuprofen like Skittles, and it wasn't doing me any good. I went to the emergency room, and the doctor was like, sit down on the bed, we'll get you some Dilaudid. Like, they loaded me. I didn't know where I was, my name, nothing. I was drooling all over myself, but my pain was gone. So we see varying levels of treatment too, depending upon who it is that's treating the patient. And you just need to keep in mind and have an open mind when it comes to a patient's pain, because just because you can't see it and you can't qualify it doesn't mean that it doesn't exist. Anybody have any comments or questions on that?
My father was addicted to pain medication. So I have a real grudge against it. I don't know if you want to call it a grudge. I mean, I just don't agree with it, because he could go over there and just get medication anytime he wanted it.
And our personal experiences a lot of times color our professional lives, how we treat patients. And I'm not telling you that the way you feel isn't legitimate, because I mean, that's your personal experience. You have every right to feel that way. I think that means that you as a provider are going to have to be more conscious, though, of that every patient that we encounter,
it's not an addict. I know that.
Yeah.
But my dad had never took pain medication until he had bladder cancer. And they took his bladder out and made him a new bladder out of his small intestines.
Wow.
Yeah.
And this was, how long ago was this? 20 to 30 years?
No. It might have been about 20.
Yeah. So basically, if it was about 20 years ago, what I imagine happened is after his surgery, his doctor started giving him a bunch of oxycodone and stuff like that because they were giving oxycodone away like it was Tylenol. Yeah. And
I think it was, well, that's when we found out that he couldn't take morphine. It drove him crazy.
yeah,
Like he started jerking IVs out and everything.
yeah, that'll do it to some people, but the newer opioids they can take. And that's a whole other part of this discussion, and we can go ahead and have it since we're here. The other issue is it's kind of hard for the healthcare profession to say, well, you know, we don't want to give pain medicine to addicts, but the healthcare profession created a lot of addicts. And that's not me saying that. That's what the facts are. I mean, that's the facts.
Yeah.
And I mean, we've got a whole generation of people that are addicted to heroin and oxycodone and all that stuff because and I mean, you know, the doctors were just doing what the pharmaceutical industry said, hey, it's okay, this is non-habit forming. And they were giving out, you know, when I got my wisdom teeth taken out 20 years ago, they gave me 60 oxycodone to take home with a refill for another 60. And I mean, I had to throw them away because it got to the point where I was taking them all day. And I finally I said, this is something that I'm going to get addicted to. I had to get rid of it. But I can see where, you know, people got addicted to that stuff. And then, you know, about 8 years ago, FDA started really cracking down on it and saying, listen, y'all got to stop prescribing this so much.
But that's why I won't even take it. Like,
yeah,
if I have a tooth pulled or something, I might take it one day,
mm-hmm.
and then it's just Tylenol or ibuprofen after that.
And that's the responsible way to do it. But not everybody is able to do that. And a lot of people don't have your lived experience, so they don't know the dangers of that. They just assume their doctor gave it to them, so it's safe. So I guess the point I'm making with that is, and I'm glad that you shared that with us, is that, you know, how we assess patients oftentimes is colored by our own experiences. And so we have to be very conscious of what those experiences are so that they don't have negative impacts on our patient. So anybody else?
In his last days, he was on methadone tablets.
That's typically what they'll do when they're trying to get them off, like wean them off something too.
Yeah. Well, he tried to kill himself because he was just tired. And he took like, I think it was like 20 methadone tablets. And it didn't kill him. But he never was right after that. He didn't live long after that.
Yeah, I'm sorry to hear that. But yeah, no, it's tough. Anybody else?
It's funny you were talking about how much they gave you for your wisdom teeth. In January, I had almost 2 foot of my colon removed, and they gave me 10 oxycodone, and that was it.
Yeah,
that was all they gave me.
And they want you to stretch those out too.
Yep.
Yeah, Carrie had she had a procedure done last month or month before. And I mean, like, they had to intubate her. This wasn't like a out of office thing. Like, this was it was an outpatient, but I mean, she had to be intubated. They had to do all kinds of stuff. And they sent her home with like 10 hydrocodone. And I mean, it's like, wow, really? But I mean, you know, I get it because again, now we've got this huge problem. We got patients that are, you know, horribly addicted to this stuff. So now the healthcare system is really scared to prescribe medication, and pain medication definitely has its place. Don't get me wrong. I mean, I'm not an advocate for withholding pain meds. When I was on an ambulance, my operations director used to get so mad at me because he was like, it's like every shift you give somebody pain medicine. I'm like, well, they were hurt. You know, how do you know? I don't. They told me. I assume they were. So anything else before we move on? This is a good conversation.
Yeah, they put me on a rotation. They had me I was in the VA before I had my surgery. I was in the VA. I had an infection, and I was in so much pain. It was terrible. And they had me on a rotation where I could have Tylenol, and then 2 hours later they would give me Oxy, and then 2 hours later they would give me Dilaudid, and they just kept rotating it.
Yeah, the last time I had well, not last, only time, not too long before this class started, I got shingles for the first time, which was horrible. And I had it on my head, like right here. So every time the wind blew, like it, and if you never had shingles, it's extremely painful. It's like a small part of your skin is now on fire. And they didn't give me anything. They were like, yeah, we can't give you anything for that. And like I thought I was gonna die. So yeah, there's a huge hesitance now. And but again, and I'm interested to see what now that looks like with these. We're looking at some new data now, so hopefully there's been some change. But I would, I don't want them to go from the other end of withholding pain medicine from everybody. We want to have an equitable distribution of it, not okay, no one's getting it. So, all right. You guys are going to see the term pharmacodynamics. It's a long word. It just means how the medication is working on the body. And that's why we're going to have, we're going to quiz you all on the drugs that you can give, because it's really, really important that you all know, not just, okay, patient's having chest pain, so I give them aspirin and nitro. I can teach you guys that in 2 minutes. You guys remember that for the rest of your lives. But what does the aspirin do? Why are you giving it? What does the nitro do? What effect does it have on the body? What are the precautions for giving that medication? What are the contraindications? So it's really important to not give a patient a medication if they don't know how the medication works. And that's where the term pharmacokinetics comes in, because we want to know how is this medication going to interact with the body? What's the onset of action? So we take the medication, how long is it going to be before we start to see it? Before we start to see the results of it? Nitro has an almost immediate onset of action. So does epinephrine. Benadryl can take some time. Ibuprofen can take some time. Tylenol can take some time. It just depends on the med. Duration, how long is it going to take? Or not how long, I'm sorry, how long is it going to stay in the body? How is it eliminated from the body, through the kidneys, the respiratory tract? And then peak, what's its bioavailability? What's its half-life? When is it going to be its strongest? This is other stuff that you guys are going to be able to go through on your own. There's just one more. Oh, I'm sorry. A few of the things I do want to touch on. Patients are on prescription meds. We kind of talked about this the other day. Just make sure we're hitting anything they're taking over the counter. So again, that can be, your kratom. I guess it'd be under herbal remedies or alternative medicines, but OTCs be like aspirin, Tylenol, ibuprofen. Patients can overdose on those drugs. They can overdose on Benadryl, Sudafed, those type of things. And then any recreational drugs, and be familiar with what you're seeing in your area. I used to work in a kind of a college town, and you'd see some weird stuff. We had 1 year in one of the high schools, it kind of spread like wildfire. Students were soaking tampons in like vodka and stuff like that, and then shoving them up their rectum, and like just getting drunk. Yes, that's a real thing that people do. There's a term for it that I just can't bring myself to say. It's the street term for it. I'll say it, but you can look it up. But you know what's going on in your area, know what's prevalent in your area. Let's see.
They was doing that back in '95.
See, I didn't know nothing about that. we did it the regular way in 95. Um, so, let's see, this will all go through in the lecture. I arrested a DWI once and she was injecting meth that way. Ooh. So I learned something last year about meth addicts that I didn't know. No, it wasn't last year because I was still in the ambulance. I guess it was 3 years. I had a meth addict tell me that that, and I looked it up to see if it's true, but they drink their own urine. And so what they'll do is they will inject the methamphetamine, and then it takes about an hour and a half to 2 hours. They'll urinate and then they'll drink it because your body can't break methamphetamine down because it's completely synthetic. They can't break it down. They can't do anything with it. And so they'll inject it, drink their urine, and it's like concentrated methamphetamine. And they will, like when she told me that, I didn't know what to say. And that's like something that she did. Like she was, there's what I'm looking for here. I was like, wow, that's a lot. All right. Let's see here. The rights of medication administration. So
One question, can I answer one or ask one question?
yeah, of course.
So what if it's the right medicine and everything, but what if you don't know how the patient's gonna react to it?
Sometimes you don't. So let's go back to my example of my patient that I gave the sedative to, and he just,
Yeah, that's what I was saying. You know, I mean, how can you feel bad? I mean, I understand the part of, how you feeling like you killed the person, but you didn't know his body was going to react that way.
nope, you don't. And there's going to be times when you're going to have patients that are going to react in a negative way to a medication that you gave. Some people are allergic to things. Some patients have never had nitro before. I'm one of them. I've never had nitro before. And some patients are allergic to it, and you don't know until you give it to, So, I mean, there's
top of your head's blowing off.
What's that?
It feels like the top of your head's blowing off.
Oh, nitro does?
Yes.
I've never had to take it. Knock on wood. But I mean, those are situations where again you'd be protected under, Good Samaritan laws and all that stuff. But you're doing what is within your standard of care and your scope of practice. The patient just had a negative outcome because of it. But we have our rights. It used to be like 6, then it was 7, and now we've got all these here. EMS is a little different because the right patient is the patient that's in front of us. We rarely are dealing with more than one patient, but the right patient, is this the person that should be getting this medication? Are we giving the right med? And not just are we giving the right med, but are we giving it for the right reason? Great example. We're going to give a patient albuterol, but are we giving it for the right reason? They're having trouble breathing. We listen to breath sounds. We think we hear wheezing. We give them the albuterol. Turns out it wasn't wheezing, it was rails, and they had fluid in their lungs, and now we're flooding. So did we do enough to assess that patient and make that determination before we gave it? Right dose. If we're not sure what the dose is, we can just look it up. It's protocol books for. Right route. Are we giving it the right way, in the right area, at the right time? Are we properly educated on what that drug is going to do? And are we taking the time to explain to the patient the effect it's going to have on them? I'll tell the patient, if I'm getting ready to give them nitro, listen, I'm giving you a drug. It's going to dilate the veins around your heart, but it's also going to give you a headache, and it's also going to make your face feel like it's on fire. Let them understand what the side effects are going to be, and then let them know they have the right to refuse that medication. Just because they're in the back of your ambulance does not mean that you can force feed them whatever medication that you want to. They have a right to know what that med's going to do to them, and they can tell you no, they don't want it. You don't have to get consent before giving every single medication, but I'll tell a patient, I'm gonna be giving you this medication, this is why, this is how it's gonna make you feel. And if they say no, I don't want that, cool. You sign right here saying that you're refusing, that standard of care, and we'll take you on to the hospital, no problems. Right response, did we give the med, and did they respond the way we wanted them to respond to it? And then did we document it correctly? The rest of this stuff is all covered in the lecture, so I'm not going to bore you back through all this again. I really just kind of wanted to have the conversation tonight about, the incorrect drug administration, and then make sure we had a conversation on equity and pain management. And I want to circle back to that real quick. Just say, well, as an EMT, we're not going to give analgesics. We're not going to give, well, you'll give analgesics, but you won't give like fentanyl or, morphine or something like that. But that doesn't mean you can't be an advocate for your patient. It doesn't mean that you can't say, like, listen, this patient appears to be in a lot of pain. You don't get an argument with your partner about it, but be an advocate for your patient. Paint that picture, set that precedent. This patient's in pain. We want to treat them appropriately for that pain. Anybody have any questions or comments? Does anybody have anything they want me to go over? All right, well, there's nothing. Then there will be like I said, like a 1-question quiz that's based on this lecture. Okay, now I will post I'll post a recording of the lecture on Compass so that you guys can review it, and I'll post it under this week, so you won't have to go down to the resources. I'll also post the video lecture for SHOC, so that you can go ahead and take a look at that one, because you'll have one on the chapter, but I go a little more in depth in this one. And so I'll post the recordings for that, along with the distributive, distributive, obstructive, and I think it's cardiogenic shock. I got 3 different videos on it. I'll post those for you all. And as always, if you have any questions, hit me up. I went on ahead while one of the videos was playing, and I posted the Discord server. I've already got, I think, at least 1 student. Let's see. Whoever Nerdism16 is, well, I love it. We've already got 1 person on the server, so you can go ahead and get up with that. If anything pops up, hopefully we won't have any issues like this again, but if anything pops up, I'll hit you guys up on there. And that'll be that. Anybody have anything else I can answer for you? Which notes are you referring to, Diane?
You had typed up a whole bunch of notes, and I started taking pictures of them, but then you said you were going to post them, so I stopped taking pictures. You were typing it up.
The patient assessment one?
Patient assessment, yes.
Okay, it's on there. It might not be open to where you can see it. I'll open it up. So I'll do this. I'll fix that whenever I'm putting the resources on there.
Thanks.
Anything else? All right. You all have a wonderful week. We will see you guys Monday. Shoot me an email if you have any questions before then. Y'all have a good day.